Good afternoon, everyone, and welcome to this session of the European Observatory's Summer School, not held in Venice this year as usual, but being held virtually for obvious circumstances, obvious reasons, which we'll be talking about today. I want to go back to the 1980s, and those of people of my age can recall how a new disease appeared at that time, which changed the way we thought about patients' rights, engagement with patients, infection control, the availability, the production of medicines, all sorts of things had a huge impact on the organization of healthcare, and that was HIV/AIDS. Now, as we came into 2020, we have another new viral disease. We saw it spread across the world, and as it came into Europe, we saw scenes in northern Italy that threatened to overwhelm hospitals, and we could see that that was going to spread to other countries. Now, of course, in the initial stages, there were enormous problems. People were coping heroically with insuperable difficulties, but they coped. And so far, at least in the rest of Europe, we've managed. That's not been the case in other parts of the world, in Latin America, for example, in parts of the United States as we speak, in large parts of Africa. But people in Europe working in hospitals have managed to cope. And they've done so remarkably. They've done so in a lot of different ways. They've had to change the way they work, quite literally, because they're now working in full personal protective equipment, which is uncomfortable, difficult, challenging when you're doing many procedures, causes problems in communicating with patients and so on. But that's only the beginning of it. They've also, in many countries, particularly those that started off with a limited hospital capacity, have expanded that capacity greatly in different ways. Most of the expansion has been within existing facilities, so turning existing hospital wards into intensive care units, but sometimes really struggling as they've filled up corridors with beds and moved equipment around patients. And they've found new ways of working, new team working, because this disease is not what we thought it was at the beginning. Much of our thinking was based on the idea that this was a viral pneumonia, like the viral pneumonias people were familiar with. But we've now recognized that it is much more than that. It's a complex, multi-system disease affecting not just the lungs, the cardiovascular system, the kidneys, the brain, the vascular endothelium. So it's affecting all parts of the body. And not just in the acute phase, but it's also affecting people as they go forward, as they recover from it. Health systems have also adapted in other ways. One of the things that we in the United Kingdom are most proud of is the way in which the health service has reorientated itself to ensure as far as possible that patients who are being treated are entered into clinical trials in an organized way. So we don't have lots of little trials here or there. We don't have, as is the case, for example, in North America, where large numbers of people are being treated with convalescent plasma, but we're not doing it within trials. We don't know what's going on. And as a result, we've had some remarkable advances in our understanding, recognizing that dexamethasone, for example, has a beneficial effect in people who are severely ill, and demonstrating that hydroxychloroquine does not help people, and so on and so forth. There's lots going on there. So what we're going to do today, continuing the theme that we've had throughout all of the summer school through earlier this week and last week, where we were talking very much about the changing role of the hospital, is to bring it right up to date and look at the hospital in a COVID pandemic. Now, we've got two outstanding speakers today, both of whom are speaking from hands-on practical knowledge and experience. One who I'll introduce in a minute is Alison Pittard, who is the president of the Faculty of Intensive Care Medicine in the UK. And she has been in the lead in developing policies and practices for responding to the COVID pandemic, and particular with this massive expansion of intensive care facilities here in a country where we started off with very limited capacity. And then we'll have Mike Roberts, who is, has a number of roles but in particular as the managing director of UCLPartners, a clinician on the front line who's been leading in the work on building new hospital capacity in London. He'll be telling you about that. So before we go further, let me just do a bit of housekeeping. This is a participative process, obviously not as participative as if we were in San Servolo in Venice, where you could all talk to us in person and we could chat at the coffee breaks. We can't arrange that, unfortunately. But what we have is two facilities. One is a chat box, and you can see the chat at the bottom of your screen. Now that's for administrative processes. That's if one of us has inadvertently muted ourselves, or if something has gone wrong or you can't hear, things like that. So that's for the basic housekeeping things. But the other bit at the bottom is the Q&A. And that's where we would encourage you to put in questions that you want to address to the panelists. And we'll come back to those at the end. But with the Q&A, it's important to note that we will try to answer some of them as we go along, but you've got a thumbs up like that or a thumbs down like that. And that will allow you to say you particularly are interested in the question, and that will move it up the hierarchy. So we'll take it up higher and increase the probability that we'll be able to get through to it in the discussion. So remember those two separate roles, the chat role and the Q&A. And the Q&A is your opportunity to ask questions. And at this stage, I'm going to ask Annalisa if there's anything that I've forgotten. And if there is, maybe she could add it in. Is there anything, Alison? Annalisa? Nothing so far?
No, perfect, Martin. Thank you.
Good, thank you very much. In which case, I will then move on to our first speaker. And it really is a tremendous pleasure to have Alison talking to us, who, as I say, leads the Faculty of Intensive Care Medicine in the UK and really has done an amazing job in developing policies and practices to respond to the pandemic. And Alison's talk will be pre-recorded, but I'll pass over to you now, Alison, please. Thank you very much.
Thanks, Martin. I'm not going to say much before the video starts. As Martin said, I pre-recorded it because I'm not in my normal place to present, and I wasn't so sure on the internet connection. So what you're about to see and hear has been pre-recorded, but I am here live and I will be able to answer any questions that you have. So I think now's time to start my presentation. Thank you. COVID-19 has challenged health and care systems around the world. Critical care was a poorly understood specialty, and we've struggled for decades for recognition and investment. In the UK, we were only recognised as a specialty in 1999. However, the pandemic has thrown us into the spotlight, and our surge resource has become the de facto overall capacity of the NHS. Although we do undergo regular testing of our emergency preparedness and response plans, nothing could have prepared us for this. Many have likened it to a tsunami. We could see what was happening in China and in Italy, and initially I think we were in denial. Then came the realisation that it was definitely coming our way, and everyone jumped into action. A state of acceptance followed, where we just got on with the job. Now we're left picking up the pieces, trying to restore services that were suspended, making our systems COVID secure, and learning from our experience to better prepare us for future surges. So to describe what happened in critical care, I'm first going to set the scene by outlining the situation before the pandemic, explaining how we prepared for the unknown, how we managed the peak in admissions, and what we're doing now as we emerge into the brave new world. Critical care is required for much of the acute hospital to function. However, to many, it remains a mystery as to what exactly goes on inside a critical care unit. People know that a surgeon operates, that a dermatologist specialises in skin problems, but we just look after sick people. So what's special about that? So as other areas innovate and expand, The additional critical care capacity that may be required is not appreciated, and therefore our ability to support this expansion and maintain a high standard of care becomes threatened unless there is adequate investment. At the beginning of the pandemic, the UK had around 4,000 critical care beds with recognised standards for staffing and working patterns. In relation to the population, and in comparison with other countries, this is low. This means that in order to care for all patients referred, we have to run at near maximum capacity, so we're less nimble in terms of responding to the unexpected. The heavy and often stressful working environment has resulted in staff recruitment and retention issues, and 40% of hospitals report that they have beds closed due to staff shortages. As a consequence, it's not uncommon to have to cancel elective surgery on the day due to lack of critical care capacity, which must be devastating for patients. So from this starting point, what did we do? So we'd watched China and Italy respond to the disease. What was interesting though was how it affected the populations differently, i.e. the younger in China were sicker as opposed to the older population in Italy. Trusts were initially asked to double their critical care capacity, but in early March, as we saw Italian hospitals becoming overwhelmed with critically ill patients, it became increasingly obvious that our 4,000 beds would be wholly inadequate, and trusts were asked to double again their critical care capacity. The natural place to look to expand into were operating departments due to the availability of anaesthetic machines that would be capable of ventilating the critically ill, and also the infection prevention benefits of individual patients in an operating theatre or anaesthetic room. London were always several weeks ahead of the rest of the country in terms of patient numbers, and seeing what was happening in London and the concern that the NHS would be overwhelmed precipitated plans for the Nightingale hospitals. We'd all watched in amazement in China as they built a new hospital in a matter of days, but we never thought that we would be doing anything like that, and here we were considering actually something similar. It became obvious also that we would not be able to deliver critical care the way we used to. Not only did we need to increase the number of beds, we needed more staff. We started off with insufficient numbers to manage the baseline number of beds, with 10% of nursing posts being vacant and 50% of units saying they had consultant vacancies. You can't train intensive care staff overnight, therefore we needed help from other healthcare specialties and professions. This meant rapidly developing teaching materials to facilitate the delivery of education and training to a broad mix of people. To maintain patient safety, our staffing was temporarily amended from the normal 1-to-1 critical care nurse to patient ratio to, at a maximum, 1-to-6, depending on the extent of the surge capacity. Among healthcare professionals, there was a real feeling of camaraderie and belonging, and the majority were very keen to be involved. But it did create some tensions. On the one hand, there was a need to train staff in many areas, and doffing of personal protective equipment, fit testing for FFP3 face masks, and in preparing them for work in what would be to them a very alien environment. In order to do this, staff would need to be relieved of their normal work, which for critical care would mean cancelling planned surgery. Of course, this would mean an increase in waiting lists and an inability to meet agreed contracts. We were seeing what was already happening in London and knew, just like a tsunami, it was coming to a place near us very soon. So getting ahead of the wave and being prepared was absolute. We knew from the Italian experience that 5% of patients with COVID would become critically ill, and therefore we were going to need extra equipment, including ventilators, in order to be able to safely manage patients. Manufacturers of our critical care ventilators make them to order, so there was a very limited stock immediately available, and it became apparent that they would not be able to manufacture this equipment at the rate required. So we needed something that was quick and easy to produce, but more sophisticated than a pair of bellows. The rapidly manufactured ventilator specification was published on the 20th of March, opening up the market for all sorts of companies to try their hand at making ventilators. At the same time, we had to rationalise our drug usage, as anaesthesia used many of the same medicines as critical care, and there was a need to conserve some of these for the critically ill if there were no alternatives. The other big change we had to get used to was the wearing of the personal protective equipment for prolonged periods of time. So, having put systems in place and being as prepared as we thought we could be, what did we actually do? What was it really like? And what did we learn as we went along? The peak incidence for COVID was over the Easter weekend. This data, which is from our National Audit Programme, shows that at that time there had been over 6,500 admissions, with almost all of these occurring over a 2-week period. Now, if you consider that number alongside our normal critical care capacity of 4,000 beds, it gives you a feel for the enormity of what we were dealing with. However, the wide geographical variation, which is shown here, meant that the experience has been very varied around the country. London have borne the brunt of this and were overwhelmed very early on, leading to one hospital declaring a major incident as they ran out of critical care capacity in their hospital. To date, there have been over 13,000 admissions. During this time, some staff were actually unable to work due to isolating themselves because of having symptoms of COVID, or a member of their family had symptoms. And this was before testing was widely available for staff, and we had to fight to raise awareness of the impact that this was having on our workforce and the ability of us to be able to care for the rapidly increasing numbers of patients. Some staff were also unable to work because they were clinically vulnerable and had to self-isolate to protect themselves. All this and the extreme working conditions had a major impact on staff morale, many of whom were actually really scared of being at work in a high-risk environment and practicing outside of their comfort zone. There can be no doubt that this has had a negative impact on staff health. So what about the patients? Well, there was initial concern, as in Italy, COVID was affecting a younger population when compared with the experience in China. However, in the UK, there doesn't seem to be any difference between no COVID and non-COVID pneumonia in this respect. There is a difference when we compare the requirement for invasive ventilation in the first 24 hours of admission to critical care. We now know that this is partly due to the effect of COVID on the clotting system. Significantly more COVID than non-COVID patients needed invasive ventilation, and this has changed dramatically over the course of pandemic. Initially, around 80% of patients were ventilated almost immediately. Throughout this time, we've had very good communication links with our Italian colleagues, and of course we saw images of hospitals in Lombardy being overwhelmed with sick patients in corridors receiving non-invasive ventilation as there were no critical care beds. It became apparent that some patients actually managed extremely well, and Italy recommended that we consider non-invasive ventilation for some of our patients, which we did, but this required a different type of ventilator to the sort that we had commissioned. This meant not only had we modified the original ventilator specification, as the patients were sicker than expected, we needed to procure a different type in addition. The increased use of non-invasive ventilation, which could occur outside of the critical care environment, increased demand on organisational oxygen supply, and there was a risk that it could cut out completely. This resulted in a critical incident being declared in Watford, as this issue had been identified and led to NHS estate departments around the country exploring their oxygen supply capacity. The other issue we had was with renal support. Initially, experience had suggested that the incidence of renal complications was low, but as we progressed through our surge, this changed and we began to have supply issues with equipment. Ultimately, we were able to manage, but these experiences have informed our plans going forward. This is one of many images used during the pandemic to highlight how well the NHS had done and that critical care capacity did not run out. It infuriated many of those working long hours in uncomfortable personal protective equipment, in unfamiliar environments, caring for the sickest patients they had ever seen. Under normal circumstances, we would expect to run at a maximum 80% occupancy, so that this spare capacity would give us some flexibility to respond to the unexpected. According to this data, we had lots of spare capacity. In reality, when you look at this chart, it is easier to see that nationally we were already running at 80% of baseline capacity, but this was only achieved by stopping almost all normal activity in the hospital. It also doesn't take into account that many of these beds were in operating departments in an attempt to separate COVID and non-COVID patients, and they were managed by non-critical care professionals. The government appeared to be patting themselves on the back, while critical care staff were on their knees. You can imagine what this did for staff morale. So, where are we now? How are we unlocking the NHS to restore some of the suspended services? What have we learned during the last few months? And what does the future look like for NHS hospitals? I have alluded to the impact this had on staff health and well-being. Not only has it been hard, the constant talk about having enough ventilators, whilst omitting the important point that you need trained personnel to manage them safely, has been quite demoralising. Many critical care staff have left or plan to leave. But on the positive side, being redeployed into critical care has fueled a desire in many to change course or to even return to the specialty, which is fantastic news. It's also created a mutual respect, as before this we had all been working in silos, but we now have a better understanding of our colleagues in other areas about what they do and the challenges that they face. So this has been a real positive. We always knew we didn't have enough staff, but COVID has really highlighted this, and I'm delighted that we received an extra 100 intensive care medicine training posts this year and have recruited to almost all of them to start next month. Critical care nurses and allied health professionals have also been the focus, and recruitment drives and incentives are currently being looked at. One of the real highlights for me is the realisation that we need a flexible workforce. For too long, doctors have had to choose fairly early on in their career what specialty they wish to pursue, and it's then very difficult to change your mind later on. Although this works well for manpower planning and elective care, it's not so good for the individual or for the flexibility and resilience of the system. A teams-based approach to healthcare delivery might be the way forward, looking at what the service needs first and then describing training programs to provide individuals with the skills to deliver this care as part of a team. This is all a very new concept, but also an exciting one. Imagine a situation where we have staff who could be deployed to any acute area of the hospital in response to demand. As the pandemic evolved, we had to change the way we use certain drugs to protect the supply for the critically ill. Also, new treatments were recommended, so the way we manage patients was not only different from normal, but changed frequently throughout the pandemic. We also hadn't appreciated how much we relied upon relatives visiting to pass on information, albeit informally, at the bedside. The teams involved in communicating remotely with relatives didn't have an easy time. The importance of mutual aid between hospitals became even more apparent when some parts of the country were overwhelmed whilst others waited for their first admission. I'm very pleased to say that this has been recognised and there are plans for a nationally funded critical care transport system, which is fantastic. It's very easy to criticise the way things have been managed during the pandemic. We can't change the past, but we can influence the future. The NHS coped, but only by stopping most of what we normally do and focusing on COVID. As lockdown eased, there was governmental pressure to resume normal services. But this, again, has caused angst amongst the critical care community, as well as others, as we were still working extremely hard and were heavily reliant on our anaesthetic and theatre colleagues. Just as the pressure from COVID was easing and we could see light at the end of the tunnel, the thought of staff returning to their normal areas would deplete the critical care workforce. It was almost like critical care had been forgotten again. Not only would we lose the staff who had helped enormously during the pandemic, we would be expected to support elective work. The other thing organisations have had to do is to develop separate clinical pathways for COVID and non-COVID patients. In some hospitals, this has meant providing critical care in multiple areas, meaning an overall reduction in deliverable critical care capacity. It's been really difficult to raise awareness of this and for it to be taken into account when elective work is being scheduled. And again, this has had an impact on staff morale and well-being. But considering our overall capacity is important if we are to be prepared for a second wave or future pandemic. Many hospitals were running at almost 100% capacity pre-pandemic instead of the recommended 80%. Accommodating more and more elective work into this reserved capacity means that we no longer have the flexibility to respond to emergency situations, and this is a symptom of chronic underfunding. Pathway separation, isolation guidance, and infection prevention and control guidance all have negative impacts on productivity. And I think along with different training models, we need to explore new ways of working. This is a once-in-a-lifetime opportunity to shake things up and modernise the NHS. The adoption of digital technology and remote working has revolutionised things over the last few months. It has brought forward plans by many years and is one of the great legacies of COVID-19. I think it will change the way clinical care is delivered and again could have huge benefits for patients and staff. I've always felt that it's difficult to manage elective and emergency care side by side, and perhaps now is the time to separate these pathways, either in a single organisation or have each pathway delivered in different organisations. This would protect the elective care, facilitate scheduling, and give patients a better deal. I hope that some of the £3 billion the government has given to the NHS is invested in critical care so that we can effectively support both elective and emergency care. So what does the future hold for hospitals post-COVID? What have we learned? I think initially we must ensure that staff have time to reflect on their individual experiences, to refuel and consider their own future. They must also be appreciated for what they've done, not necessarily financially or being called heroes, but by being recognised for how hard it has been and to focus on their health and well-being going forward. Staff who truly feel appreciated will always go that extra mile. We also have to be ready for the possibility of another surge in COVID cases corresponding with winter flu. We also need to try and retain some routine services should this occur, but there will be a drop in productivity. We shouldn't have any supply issues for personal protective equipment or other equipment and consumables, but we do need to ensure that we retain resilience by keeping redeployed staff up to date with the training they received and also adopt any feedback from them into our future plans. In the medium term, there are some changes that could be implemented to try and maintain productivity, both during a future surge and in general. There are different models of service delivery around the country that have been shown to have a positive impact on patient outcomes and also support routine scheduled work. For critical care, this means implementing our enhanced care guidance, which has been recognised by NHS England as a way to provide safe and high quality care for high-risk surgical patients who would normally be admitted to a critical care unit. Many of these patients don't actually need our services, so developing this model would liberate critical care capacity, would create other areas in the hospital that could flexibly and rapidly become critical care units during emergencies, and would also support retention of the skills acquired by those staff redeployed during the pandemic, as they will be utilising these on a day-to-day basis whilst caring for this patient cohort. One of the other things that COVID has exposed is the long-term impact that critical illness can have on both physical and mental health of patients. As critical care professionals, we've known this for over 20 years, and it can result in patients either remaining in hospitals as their rehabilitation needs cannot be addressed in the community, or even worse, they're discharged and never attain their true potential as they cannot access any rehabilitation. We published interim guidance on this during the pandemic and will have a definitive document by the end of the year, but recognition of this gap in care would expedite patient discharge back into the community, not only improving their quality of life, but also freeing up much needed hospital capacity. I think in the long term, the opportunities for the NHS are really exciting. Its work has been appreciated. Many people volunteered. Previous employees came back to help and now wish to return in some capacity. And we have demonstrated what can be done in a much more nimble way if we remove the administrative tiers we normally have to go through. For me as a clinician, this has been liberating, seeing ideas and plans implemented with positive results in a relatively short space of time. This is very rewarding and can only encourage innovation. This and the adoption of the digital technology that is available, I think, is what the future holds for the NHS. So we've come a very long way in a short space of time. It's really important to learn from our experience, taking forward the positives, bringing staff along with us, making the NHS even better and improving care for our patients. I think the future really is bright. Thank you.
Okay, just struggling with the mute buttons on my new laptop there. Thank you. Thank you very much. That was fantastic, and
You're welcome.
with an image for those of us who aren't actually there. And I just, before I introduce Mike, actually maybe to reflect a little bit on how that connects with some of the things we were talking about earlier in the summer school. And we were talking about the changing role of the hospital, our new book that is coming is out, although I haven't yet managed to get my hands on a copy because of all the problems with the pandemic. Which actually echoes many things you were saying about the way that we need to do things differently, separating elective from urgent care, and team working and flexibility across hospitals. Because so often we've had this idea that the hospital is an entity on its own, and the need to have networks, which we'll be talking about more tomorrow. In fact, you okay? Yeah. Good. And so that resonates very much with that. And of course, much of what you were saying was about the working across disciplines and flexibility, where some of the things we picked up in the session on task shifting last week, that Claudia and May were talking about our report from the European Commission expert panel on task shifting, where we talked about shifting tasks between health professionals and patients and their carers, and between health professionals, patients and carers and machines. And all of these things are up in the air. And just in the same way as we were talking earlier before the session started about the way in which we're all now living in Zoom, and we'll be traveling a great deal less in the future because we can do these things. Although hopefully, as I say, we will get you to Venice at some stage in the program for the summer schools. We're changing the way we're working in clinical medicine as you are. It's a long while I work in clinical medicine, but with telemedicine, with remote consultations and all sorts of things. So very, very wide range of changes that are taking place. And of course, this isn't the first time. I already said how the advent of HIV changed what we did. But before that, the decline of tuberculosis and of polio, for example, fundamentally changed the nature of orthopedics and of thoracic surgery. And so once again, we're seeing infectious diseases and the way in which they're changing, impacting on the hospital. So with that, thank you very much, Alison. Can I just encourage people to put in more questions, because we're not getting very many of them at the minute. We've got a number, but please keep your questions coming, because we do have a Q&A session at the end. And with that, what I'm now going to do is to pass over to Mike Roberts, who is going to take us through his experiences in London with the expansion of capacity. Over to you.
Very good. It is quite actually being here in your somewhere in the UK, speaking in internationals and knowing whether anybody can see or hear you, but I'm assuming that you can. My name's Mike Roberts, Martin has said, and I'm managing director of UCLPartners, which is an academic health science system, and I'm by trade a respiratory physician, so was quite involved in the pandemic response in a number of ways. I'd like to cover in the next 20 minutes or so these areas. A little bit of UCLPartners is as an academic health science system, why I think organisations like ours are important in terms of managing and responding to crises like a pandemic, but it doesn't have to be a pandemic. Secondly, something around how we turned a conference centre into a hospital, a pop-up hospital of the Nightingale type that Alison referred to earlier. And a little about how we for learning health system within the NHS Nightingale London Hospital, and how that then turned into a national and international learning collaborative for intensive care units. Finally, some of the lessons we might take from that from the future, because I think we'd be the poorer if we just get through this by surviving without thinking about the implications for the longer term. So UCLPartners as an academic health science system is a collaboration between a number of academic institutions, clinical research centres, NHS organisations, but working with industry and the commercial sector and charities. And what we do is try and get people to get to work in collaborations that wouldn't otherwise naturally do, and promote changes to optimise patient care and population health in a way that those organisations working on their own are much less likely to be able to do. And we do that at some pace and scale. So we're situated in southeast England, as you can see there, within the United Kingdom, and we cover most of north central and east London. You might just be able to see the River Thames there at the bottom of that graphic on the right hand side. So north central and north east London, but we also cover the population and partners within the two home counties of Essex and Hertfordshire, and we also have an enclave within Bedford. For those regions, we have a population of 6.2 million people that we cover, and in London, about 4% of that population from Black and minority ethnic groups, who were, as I'm sure you are aware, particularly affected by the COVID pandemic. We have as our partnership, and we are a partnership organisation, 23 NHS trusts, with altogether 29 NHS hospital sites and 9 academic institutions, mainly universities. And that collaboration of working across universities and NHS trusts has enabled us, I think, to do some things within the pandemic which other organisations were unable to do. And I think the other thing we could do with our pandemic was to take some time out to think, whereas, as you've heard from Alison, our NHS organisations were really full of just surviving from day to day. What we call the pandemic were a number of national and regional commissions in mental health, redesigning services, and organising new career pathways for new professional grades that came in to supplement the workforce, because just like ICU, there are lots of shortages of staff in other areas of care as well. And we work predominantly in cardiovascular disease prevention, predominantly in the community and with public health teams. But we also had a commercial innovation arm where we linked the NHS to work with industry on collaborations where we tried to bring technology and innovation into the NHS, again, as Alison has said we need to do in the future. Well, that's one of our key roles, and using data to support the NHS to understand where it needs to improve quality. So where innovation and research are key, our academic linkages, we use those to try and inform what we do, and we use safety collaboratives and communities as a mechanism for engaging clinical teams in working collaboratively across groups of organisations which normally might even be competing against each other. So that was fine. And then COVID came. And suddenly we had to stop everything because none of those things were possible anymore, because the system pretty much, as Alison said, ground to a halt in terms of both reacting to this sudden emergency, but also in terms of being unable to manage business as usual at the same time as reacting to the emergency. So as an organisation, we felt we have 3 qualities which would suddenly be put to the test: collaborating on clinical best practice, supporting transformation in the service, and how we would put into place improvements in patient safety and quality in this changing time. So suddenly we were challenged. But as I said, one of the key things that we were able to do is we have time. We have time to sit back a little bit and to think about what needs to be done, rather than to be reacting by suddenly pouring all our staff into the ED and then into the ICU and changing all our beds based to intensive care beds. We can think a little bit more about what needs to be done. And one of the collaborations we did that I think Alison referred to was within a period of just 3 days, some of our clinical academics from University College London, working with one of our major teaching hospitals, University College London Hospital, to design with the Mercedes racing team a new non-invasive continuous positive airways pressure ventilator. And from the moment of thinking about the concept to testing the first prototype took just 3 days, and it was in production within 2 weeks. And that's the kind of thing that we were able to facilitate, bringing together all of those people, the commercial sector we work with, our academic colleagues, and our NHS partners, to do something which I've got to say would have been very difficult to do if those linkages hadn't been in place already. So one of our first asks from our partners was to help support the setting up of the Nightingale Hospital in London. And this was the Excel Exhibition Centre, which some of you may well have been to for major conferences in London. It's situated, as you can see, just north of the River Thames in northeast London, and it was adopted by one of our biggest NHS acute trusts, Bart's Trust, who are one of our partners, and they asked us to help set up the new pop-up hospital by helping recruit staff to it and by helping design the training program that would bring those staff together. And we had to move from day one to 3 weeks to the opening of a new hospital, which was to have the capacity to ventilate 3,000 patients in one place. The site is 45 hectares in size, so you can see it's a fairly sizable undertaking in every way. Some of the staffing issues were really interesting. So we had, as you heard, linkages with 9 universities, many of whom had biomedical or healthcare faculties within them, and many of the academics working in those suddenly found that their research programs were frozen, and they suddenly had the opportunity to spend more time in clinical medicine. They may not have seen that as an opportunity, but it was an opportunity. And so we were able to facilitate that process of being almost like an employment agent, working with our university colleagues to help them move into this role in the Nightingale Hospital and other hospitals as well. And then there were some other unsuspected resources within our system too. So Martin's academic institution, the London School of Hygiene and Tropical Medicine, had within it a number of postgraduate healthcare professionals from a range of professions from overseas who were in the UK undertaking master's degrees and PhDs, who suddenly were trapped in the UK because of the lockdown situation, but wanted to contribute to the system. They weren't registered to practice as doctors or nurses or physiotherapists in the UK, but they could contribute to the system. And we rapidly, working in London School, enabled a high number, over 60 postgraduate students to come and work in the Nightingale in a unique way, which I will refer to in a moment. And just to give you a quick idea of what happened, I mean, this was day one. We worked, and NHS Bart's Trust takes the credit for this, not ourselves, for setting this unit up, worked with the and logistic core of the Army, who were absolutely fantastic. They knew exactly where to source equipment. And if ever, Alison, in the future you need to find 50 or 100 ventilators, the Army somehow could pull them out of a back door for you. But everything from changing the structure of the conference centre to finding extension leads for electric cables, to trolleys, to beds, to ventilators and anaesthetic machines, to monitoring equipment, to a massive requirement for oxygen therapy, as you can imagine. The Army were on the job and brought that into the system very, very quickly, until we ended up with this, which was, for all intents and purposes, if you were to avoid looking at the roof, an intensive care centre in a hospital near you. The schematic on the left-hand side gives you an idea of how it was set up. So each little block is a block of 20 intensive care beds, and that's how it was designed to operate in units of 20 across the system on 2 sides of a large corridor about 40 metres separated. Now, here's the problem, because you've brought together a whole range of staff who haven't worked together before from different institutions, some of whom, and many of whom, in fact, haven't worked in an intensive care unit for a long time, or indeed some of them who have been out of clinical practice for a while, and suddenly you're trying to pull them together to help them gel into a team. And some of them found that quite a traumatic thought. And at the same time, dealing with a really novel condition, COVID, where the experience of managing it was zero. And whilst it's true, as Alison has alluded to, we were getting information from China and information from Italy coming over at that time, and then Spain and Germany and France, it was true to say that a lot of that initial information was not particularly close to the experience we were getting from our colleagues in the area. And we were approached by a number of intensive care units in the London region, where the brunt of the initial COVID in the UK was felt, to say, sadly, our patients are dying. We're treating them like adult respiratory distress syndrome. We're treating them like viral pneumonia, but these patients seem to be dying, and we don't understand why and what is happening and going on in that system. So as Martin said, a huge research agenda was started at that time, but the reality is that research takes months to conclude its findings, and then often weeks, if not months, to publish its findings. And even some of the cohort studies coming out of China and Italy, which were really descriptive papers, took some time. And Martin will know, we wrote a paper for the British Medical Journal, and even from the moment we put our first pen to paper to getting it published electronically, took 3 weeks, and that was really, really fast track. Now, that was at a time when 300, 400, 500, 600, 700 patients were dying each day. So can you afford to wait even 3 weeks to see what somebody's publishing in the literature? And the answer is, I think, for you and I, no. We know now. So we had to think of a different way of trying to get real-time learning into the system to inform what was going on, using the LSHTM scale as an exemplar, but then transferring that model to other systems as well. So we created what is we call a learning health system. How did we pull out from clinical evidence what was happening in real time and feed that back into the system, coupling that with the published literature and the grey literature to help inform clinicians at the front line, almost in real time, how to improve their clinical care, so that we got the kind of results, again, that Alison demonstrated, from a mortality rate of nearly 50% in ICU in March to one that came down to 40% by July. And there were 5 principles behind this learning system, in that we had to understand and identify what we really didn't know, which, to be honest, at the beginning was most things. Secondly, that everything behind this system was to inform clinicians to help patients. Thirdly, that we had to reduce the burden on frontline clinical staff in different ways, but certainly we couldn't expect them to spend their time learning online modules or to spend their time in classrooms. This wasn't going to be possible. Every patient was a learning opportunity, and we had to get this feedback loop rapidly into the system so that people learn in real time, because patients' lives were at stake. And this schematic gives you an idea of how we set that up. And I'd like to start at the bottom of the page in the highlighted area, which is called bedside. And here we created a new role, the bedside learning coordinator, a person who was trained very quickly. And this is where we used a lot of these postgraduate students who were healthcare professionals in their own countries but not able to practice in the UK to do this kind of work. And we trained them to interview very quickly, using a semi-structured questionnaire and format, staff in each of these 20-bed areas during their staff handover times, to try to understand from them what their key challenges have been during the day, and if they had any learning which they wanted to share with other units. And they would then take that to the internal data and quality and learning teams, who would try and synthesize those bits of information into thematic areas and consolidate that with any data that was coming in from the electronic patient records and other observations that were taken. They would then feed that up to the external advisory group for help and support. I'm going to major on that in a moment. And then information from that, collated with any of the experience that the clinicians were telling us that were answers to these questions, would be fed back down through to a clinical forum, which met every day to hear a few learning nuggets, some of which went into simulation for training, some of which was tested out in PDSA cycles, and some of which went to inform the larger research agenda, which we knew would take time to report, but which it was important to ensure was very related to the need of the clinical teams. And then we also put together a change implementation team. So when a change was needed, something was made to happen. It wasn't down to the clinicians to make it happen, but a team of people went in to help make that happen. And the kind of things we're dealing with here are very varied. So, for example, as Martin has alluded to, if you're wearing protective equipment, it's very hot. It's very difficult to drink when you are fully protected in the equipment, and staff were getting dehydrated. So we then developed a relationship with a company which we'd worked with in the past, who produced something like the Camel Pack. So a liquid of water reservoir you can wear on your back with a very lightweight harness with a straw that you can access behind a mask and behind a visor. And so you can keep yourself hydrated during the day. And the change implementation team brought those in. The bedside coordinators would then come into those teams and say, look, this is what you told us yesterday was a problem. Here's the solution we're going to bring in tomorrow, and then get feedback on whether that solution was helpful. Of course, there were these were clinical issues that came, why are our patients dying? It was a really, really key issue. And the external advisory group went outside the system to try and answer some of those questions. But just to, again, summarize, the role of that bedside learning coordinator was to spend time with the teams, getting insights, understanding what the key issues and concerns were, and then feeding back solutions and how the system was responding to their needs. So that made people feel valued. It made them understand they were part of a circle, and that they weren't just feeding up complaints in a sense and getting nothing back, which is very typical of the way a system can work. So the external advisory group I want to just focus on now. So a lot of these issues, of course, couldn't be solved internally. They had to be solved externally. And so UCLPartners formed this external advisory group to try and help with those issues. And at that stage, we had put this model around the Nightingale, but we were getting requests from many different partner organisations. And we started to build external relationships as well, particularly with the Intensive Care Society, but also with the Faculty of Intensive Care Medicine and the regional NHS England improvement commissioning organisations. And so in essence, what we did was pull together from, again, academic university colleagues, evidence synthesis experts and systematic reviewers to form a team dedicated to answer these questions about intensive care, clinical and other issues. Our UCLPartners communications team helped those people pull the evidence that they had sourced into a format which we called learning nuggets, bite-sized bits of information that a clinician could read in 30 seconds and understand what the main message was. This wasn't about providing a 200-page guidance document or set of guidelines. This wasn't about giving somebody a 9-page article from the New England Journal of Medicine with 140 references to back it up. That wasn't possible. It's about bite-sized nuggets. We provided clinical leadership from members from our own team, public health consultant and anaesthetist who led this team to help them focus appropriately, and admin support to arrange meetings and to distribute things. And as I said, we formed relationships with other organisations to make this really work. And that was one of the other key functions I think we played. It's quite clear very quickly that lots of people were working on these issues, but not necessarily in a coordinated way. So how could we bring people together to have those conversations, to exchange information? And one of the ways we did that was working through the Intensive Care Society to hold a series of webinars. The first two were just for the UK, and then we involved international colleagues as well. So these went out to everywhere. And these were learning exchanges. So these were clinicians coming together to report what was working in the intensive care management of COVID patients. And we'd record these. And then after that, our evidence reviewers would do a thematic analysis and pull out some consensus statements from this, which our comms team then put into a document, which usually within 24 hours, we'd send back out again through the system to inform people. Now, we put a health warning on this. These are not guidelines. This is not research-based evidence, but this is emerging clinical consensus based on the experience of people working today in intensive care across hundreds of units around the world. And in addition to that, of course, our systematic reviews are very good at looking through the grey literature and publications on a regular basis and using those to supplement those clinical consensus statements. So we were able to address specific issues that way, but also new issues that were being promoted through that dialogue we were having in those webinars. And just to remind you, at the time we were talking about this, is mid to late March and early April. And you can see from that table the death rate from COVID-19 in England only was going up dramatically to a point in mid-April of 1,000 cases a day. And at that time, as we were not doing COVID testing much in the community, these were deaths in a hospital, and a high proportion of these deaths were in intensive care, because that was the only place you could go to if you had a chance of surviving. So giving that real-time data was so important. And we as a team felt, every day we didn't report or learn something meant another 1,000 people died. That was quite a weight on us to get involved and to do something. And this schematic gives you an idea. It all started at Nightingale Learning Hospital, again, as Alison said. There were others fed information into as well around the country. We then set a regional intensive care community practice across our 24 NHS trusts and patient safety collaborative. We then set up links with national groups through the Intensive Care Society and the Academic Health Science Circle, who also then developed and copied our National Patient Safety Improvement Programme, and then internationally sharing knowledge across Europe and beyond. This is the kind of document we produced twice a week. So that would be it. That would be the consensus statements. Nothing more than that, but pithy. Lots of stuff. And these are the kind of things, just to give you an idea. And you might look at these now and think, well, we know all that. But I've got to tell you, in mid-March, we did not know these things. And these things came through emerging clinical experience. And now we have research to tell us, yes, these things are correct or they're not correct. But I do remember, for example, hearing from Italy about people suddenly dying from COVID when everyone thought they were getting better. And indeed, my own neighbour here, lived next door to me, was in hospital in the UK at that time for 2 weeks with COVID. And on the day she was told she was going home because she had come off all her oxygen and she was just about to mobilise, dropped dead on the ward, and the family were told she'd had a heart attack. Well, I know she'd have died from a massive PE because people didn't know about that then. But then we very quickly picked this up. And very soon in the UK, we were scanning patients and finding, yeah, it's happening here too. And that's why people are deteriorating. And then we found that we needed to do more than put people on thromboprophylaxis, but treatment doses as well. And that all came out of experience that we gleaned through these kind of things. And what kind of an impact did we have? Well, we found that social media was a very good way of getting things out. We didn't start that way, but our participants used social media. So initially we had 5,000 intensive care contacts who we emailed through the Intensive Care Society with these vignettes and with this information. We had 150 UK COVID-19 leads designated. We put information into Sage. People around the world, like Don Berwick, started to hear about the work and tweeted it across the States. Our own chief medical officer got to hear about these things and started to interface with us about these. And we started to write articles, and this first one went into MJ and got more interest than any article published that week. Started to describe the multi-system nature of this condition, which hadn't been properly recognised at that time. But even that article took us 3 weeks from the first sentence that we wrote, Martin, until it got into the journal. And then people started to form WhatsApp groups around what we were doing and started to get that information out into the wider world. So that was then, and what about now? So in my own opinion, I think learning health systems are something we should not ignore. The learning from me is that in a pandemic, yes, research is absolutely critical, because to get fundamentally valid responses to these questions, we need to have proper research. But in the short term, we need to think about how we collate clinical information in real time and feed that back into the system through a learning health system, which is a combination of guidelines, it's a combination of research-based grade evidence, and it's a combination of emerging clinical evidence in real time in the middle of a pandemic. But of course, life normally doesn't require us to react that quickly, but I still think there's a lot of value in getting clinical experience and feeding that back into a loop into the system so that clinicians do feel valued. And whatever we have in terms of research grade evidence or guidelines, there's always some local way of needing to implement. There's a nuance there, and getting clinicians to help you understand how to nuance and implement things is so important. And we do that at an organizational level. We have 2 hospitals now we're developing a learning health system in, but we're also working with our regional health authority to get this in place as well. So system level learning is important, just as well as organizational level is important too. And so my last slide is really, these are a list of the publications that we, as a group, pulled out of that we got published in peer-reviewed journals. But I just wanted to draw your attention to the fact that we started trying to publish at the end of March, and our first publication was in May. It took a while, even though you may think, wow, super quick to get those publications out in that time. And in the real world, that is super quick. But in that time, how many thousands of people would have died if we'd waited to get those publications out is my challenge. So thank you all very much indeed for listening. And I'm going to try stop sharing now. Thank you.
Great. Thank you very much indeed. Thanks, Mike. That was fantastic. And also to Alison. So I'm now going to try, if we've got both of you online as well, to take us forward with these questions. But maybe I can just begin, Mike, with you, because at some stage we had some discussion about how we could extend the exercise that you were doing across Europe with European colleagues. And I just wondered if you could reflect on how well that worked, or didn't.
Yeah, quite. So I think it worked partially in the sense that there was engagement from European colleagues, and we went through various intensive care societies in different countries, and we got variable responses from them. So some immediately came back and said, yes, we're interested. Others, we just didn't manage to get any traction. And we used a variety of things, using their own comms, email addresses, phoning people when there were phone numbers, asking colleagues who knew other colleagues to try and get traction. So there was a varied response, I would have to say. Having said that, for our first couple of international webinars, we did get people from France, Germany, Spain, Italy, I recall, and probably a couple of other European countries as well, and internationally there was a lot of interest as well. But what we found, interestingly, was that the experience was very different. So whilst in the UK we got very quickly to a group of consensus statements, there was a very different range of views and ideas. And I think what this highlighted to me is that this is a real, still big unknown, and that the worry is, as Alison said, that we've got a potential second wave coming at some stage. And I don't think we're still confident about how best to manage this condition. And if you ask somebody in Leeds how to manage, they may be very different from somebody in London. And even in London, I know north and south of the river, people are different. You go to Germany and ask somebody, and they have a different idea of how to manage. So there's a real potential, I think, Martin, in answer to your question, to do something much more pan-European now. Now we've got a moment, a breathing space in a sense, before we end up in this position again in 6 months and 12 months' time, thinking, I still don't know what we're doing.
Well, tomorrow we will be having a session on the COVID-19 clinical management support system, which has been set up by the Commission. So I think there are lots of really important questions, because I know from our conversations that this was really quite challenging. Alison, did you have any experience with the intensive care with your society in trying to engage beyond the borders of the UK?
We collaborated partially with Australia and New Zealand on an informal basis. Obviously, their experience at that time was less than ours. But now, particularly in Australia, that they're now having issues in some parts of the country. They're looking to us and asking us advice. But as I say, that's informally. And as Mike said, a lot of the sort of the research kind of collaboration is the remit of the Intensive Care Society. So although, we obviously engage with them, that was left to that organisation. So most of ours in terms of faculty business was informally.
Okay, thanks. And maybe that's just a comment for the people who are participating, because I think in the aftermath of all of this, if people are interested in following this up and would like to get in touch with us at the Observatory, we would be very interested to learn to what extent it has been possible to do something like what Mike has been describing in other European countries, and what were the opportunities, what were the barriers, because I think although in previous projects I and colleagues like Helena Quigley and others have looked at the development of clinical guidelines in different European countries, it's always been quite difficult to get a handle on that. So turning to the questions, and we have a few of them coming in, but I would encourage you to bring more in. And one of the questions I'm going to take is, how did the clinicians engage with this process? Was everybody accepting, Mike, of the coordinator, the learning coordinators and so on? Was there any opposition? Did people say, well, why are you telling me this, that sort of thing? Or were they willing to learn and have their views challenged?
Yeah, well, people are always different. There's always somebody who's particularly awkward in a system. But on the whole, people were very, very grateful for the opportunity, firstly, to express their own concerns, but also to share their own knowledge with other people. And I think that shouldn't be underestimated, that clinicians on the front line have a lot to offer in terms of learning, but often feel that there's nobody listening to their suggestions. And if they are able to articulate concerns, that nobody then takes any action. So having that cycle of demonstrating the concerns, but also some solutions, and then asking, if you like, a higher authority to try and come in and solve those issues, and then finding they were being listened to and the issues were being addressed, was very, very reinforcing of those positive behaviours, I think, in the system. I think if we had raised issues and said, sorry, can't deal with that, then we'd have lost engagement very quickly.
A question for both of you is from Sarada Das, and it's to what extent is preparedness planning taking account of that future pandemics may look different in terms of transmission, mortality, and so on. And I'm reminded of Adam Kucharski, one of our modelers at the school, who says, once you've understood one pandemic, you've understood one pandemic, because everyone's different. And, but leaving that aside, the processes, I guess, some of them might be generalizable. Either of you, maybe bring in Alison first, and then Mike.
Yeah, I mean, I think one of the things that we are aware of is that we do have to be prepared for the future. And as we currently see with COVID, we don't really understand why it works the way that it does. And we don't understand all the different nuances about how we should treat it. And so in some ways, it doesn't really matter what comes next, because the chances are we're not going to understand that infection or whatever it is. So it's about, I think, certainly from a hospital and particularly a critical care perspective, it's having that generic preparedness. And I think certainly within critical care, where we started off from a bad place and not having enough resource to manage the normal situation, there is now the realization that we do need more capacity, and we need to have some flexibility in the system to make us resilient. So certainly from that side of things, I think we would be more prepared, but we can never say that we'll be completely prepared, but we're certainly in a better place than we were at the beginning of the year.
Reassuring to hear that. In a book that we wrote on the role of the hospital, Nigel Edwards and myself, going back about over 20 years now, one of the first observatory books, we actually said flexibility, 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 because you can't actually plan for the future. Mike, any comment on that?
Yeah, absolutely. And I think from the London perspective, there's going to be a permanent increase in ICU capacity and the flexibility to use other areas as emergency ICU care when necessary, such as operating theatre. I think that will be built into all new hospital models. I think one thing I would add in terms of the learning, certainly in London, was that the outcomes for the more complicated and severe patients seem to be better in the larger hospitals than they were in the smaller district hospitals. And so I think the plan for the future is to turn those larger hospitals into the surge centres, rather than to have every hospital equipped to be a surge centre. So that's the model that London is likely to adopt going forward.
Let me pick you up on that one, actually, because one of the successes in London, and very much led by your predecessor, was the regionalisation of stroke services, with the concentration of bringing all patients with stroke into, I think, 8 hospitals in the capital. And that has been associated with much better outcomes than before, and been well evaluated. And in other countries, that's been quite a challenge, particularly where hospitals are very autonomous. So I'm just wondering how easy that will be. I mean, will some hospitals say, well, what about us? Why are we being overlooked? Or are they willing to accept that you do have different roles, particularly when you have a more market-based hospital environment?
Sure. And that's absolutely right. And I think that's where we need to have, if you like, a neutral partner that makes those negotiations happen. And in the past, with the stroke reconfiguration, that's exactly what the organisation that my predecessor, but one led, was that stroke reconfiguration, and a more recent reconfiguration of cardiac and cancer services onto a smaller number of sites with demonstrably better outcomes for patients, one has to say. So I think the evidence is there for the value in that. In terms of the intensive care situation, we now have another administrative structure in the NHS, which is the Sustainability and Transformation Partnership, or as they're now being called, Integrated Care Systems. And the job of those organisations is to try to reorganise services across a geographical area of a population of between about 1 and 1.5 million. So I think it will be their role predominantly to broker those discussions and compensate one unit, perhaps by moving more elective surgery, for example, into or low-risk elective surgery into one area, and then moving intensive care and more acute work into another area, and consolidating in those ways. But you're quite right. There needs to be a win-win in that rather than a loss.
There's a couple of questions about lessons learned for new hospitals and management of COVID and non-COVID patients. In Singapore and some of the Southeast Asian countries, after SARS, they actually redesigned the hospitals so you had a sort of clean and dirty section, and patients coming in even routinely when there wasn't SARS had their temperature checked and their travel history taken, and they followed a separate pathway. So really for both of you to reflect on, Alison, you also talked about the urgent, elective and urgent. Do we actually need to redesign hospitals, leaving aside the challenges of doing it in the UK, where we have this particular form of financing, which makes it very difficult to change ones that are already built? But as we go forward, should we have a new concept of how we configure the hospitals, and in what way? Alison, maybe.
Yeah, no, well, I think we've obviously learned a huge amount, and that a lot of the NHS estate is old and certainly needs updating. And I think those organisations will benefit from what we've learned over the last 6 months, and there will be some new designs implemented. And I think it's going to be very much dependent on the footprint of the individual hospital. I think what we need to, the NHS, my view, is very inefficient. And I think one of the inefficiencies is because of the urgent and emergency care having to be managed alongside elective care. And elective planned care is very easy to predict. Most people will follow a predictable pathway. And perhaps, I visited a hospital in Rome many years ago, and the intensive cares were completely separate. The elective care, they knew what the beds were going to be like, and no cases were ever cancelled. So I think there is something to look at reconfiguring things. Whether that means redesigning is going to be very different, dependent on what we think the changes need to be. And of course, at the moment, we're still learning. So I don't think we can make a final decision as to what we should be doing yet. We need to get through this out the other side and then reflect and make those decisions then, rather than now, because we're still in the middle of it, just not quite as burdened as we were a few months ago.
And of course, we will have to look at the capacity in hospitals. It's always interesting for us in the UK when so many people say, well, what about how many hospital beds do we need and how do you cope with running at capacity? And then we have these discussions in the observatory with Reinhardt and the others, and coming from Germany, they say, well, why are you asking these questions? It's just simply not an issue in a number of other countries where you don't have to have patients. I remember as a junior doctor having patients all over the hospital, and that's one of the inefficiencies actually, because nobody's in the right place. Mike, any thoughts on how we would redesign? You've got a nice, shiny, relatively new hospital in University College London, which we actually used as a case study once in terms of hospital design.
Yeah, so I think the problem is that the estate is pretty much fixed. Although there is going to be a new hospital building programme, it's going to be interesting to see whether that will be informed by COVID. I suspect it will be. But for the majority of the NHS estate, it's too late to make those changes. I think what might happen is at a regional level is what I hinted at earlier with the intensive care, which is about configuring some sites or parts of some sites as cold elective sites and others as hot sites, which will see acute work with COVID. But even the cold sites are still susceptible for patients with asymptomatic COVID, so that there will have to be changes to the way that patients are managed, and the throughput will inevitably drop off. And I think in order to be able to cater for that, there has to be an increase in elective ICU capacity to manage people who have unexpected complications on different sites as well. So it's a complicated situation. I think Alison's absolutely right, is that we don't know yet what the right way forward is. We're still learning about it. But I'm convinced that there will be significant changes in service configuration and in some design in hospitals to try to separate out at least the elective from the non-elective flows.
I've got one practical question for you, Mike, and I'm fascinated in the answer as well. When you moved into the exhibition centre, how did you deal with all the things that you needed, like specific sewage systems, radioactive waste disposal, mortuaries, all that sort of thing?
Yeah, so you're absolutely right. There were some really interesting questions. Those are the most, they seem like the most complex, but some of the simplest things were the worst things, and I'll come to that in a moment. So, and the bottom line was that we brought with us a whole load of engineers from the local authority, plus the army, plus those that came from Barts Health Trust, and between them, they made things happen which couldn't happen during, let's say, peacetime. So it was a little like a wartime. Various things and regulations were quickly sorted, rather like the permissions to produce that CPAP equipment in 3 days, which would have taken 2 or 3 years to get regulatory approval in another time. Suddenly everybody was very happy to allow us to use radioactive materials in an area which normally they wouldn't be allowed, and to dispose of them in ways which normally would not be allowed, but there were mitigations put in place. So I think everybody basically changed their views about the world to a can do rather than a can't do. But one thing that really was a major problem, and it seems like a simple thing and you think there must be an answer, but there wasn't, was the lighting. So the lighting in the conference centre was either on or off. And the lighting, there were many thousands of these units, couldn't be dimmed. It was just not possible. So you had them on or off. So you had daylight or you had darkness in the conference centre, which is extremely difficult. So a huge number of mobile lamps had to be brought in to help light the place in the evening and at night time. And that was probably one of the biggest logistical challenges. And it just shows that it's the things you don't think about. So somebody thought about radioactive waste right at the beginning and disposal of sewage and all those kind of additional things, but nobody thought about the lights because we flicked the switch and they were on.
Yeah. In one of the earlier observatory books, we worked with architects. Fascinating exercise, and we were looking at hospital design across Europe. I have to say the UK with the private financing model didn't come out well because it's not flexible. But what was striking, particularly the Netherlands, where when hospitals were built, there was a huge amount of flexibility built into them. So if you needed additional ducting and pipes and things like that, you could do it without lifting things up. You could move walls around and so on. And so that flexibility being built in from the very beginning, but it is very, very challenging when you have our particular model of design and build, which also exists in Spain and to some extent in Italy and Portugal. but is quite problematic. Alison, do you want to come in on that?
No.
Oh, sorry. Okay. One thing, just because we're getting to the end and we're going to have to wrap up in a minute, but just one question for you both. One of the, I think, great successes, and we talked about it earlier, was getting so many patients into clinical trials in the UK. Really getting and having coordinated clinical trials, so everybody wasn't just doing one here and one there. I mean, there's dozens of trials that are going on across Europe into hydroxychloroquine, even though we now have the answer. So we don't actually need that anymore. But things like, there are other things like the convalescent plasma, for example, that we need more information on. We had the recent study from Southampton on interferon. Why did that work so well, either of you?
Well, I can come in a little bit on that. So I think a lot of funding for studies comes through the National Institute for Health Research in the UK. And they very quickly said to the researchers that they were sponsoring, stop doing the research you're doing. And here are a number of national programs and projects related to COVID that we want you to apply for with additional funding, or to use your current staff and redeploy them in this area. So there was a pretty good top-down response in that sense. And then if you were to take, for example, again, the Nightingale example, the local medical university, Queen Mary University of London, appointed a lead researcher to work with the healthcare system there, and nobody was allowed to enter a patient into any trial in the Nightingale without going through the research committee that was put up for the Nightingale Hospital, and none of those research studies that were approved were outside the NIHR portfolio. So every single one of those studies at the Nightingale was part of that national portfolio. And because there was a local medical school, because it was a teaching hospital, because there was a research team set up there, every single patient who went into that unit was offered to be part of a research study. So it was set up immediately. I think it's one of the strengths of the academic system in the UK is that we are very strong in academia. And so when there is a call to arms like that, a whole host of people got involved. And as I said, we recruited a lot of academics into the clinical staff as well. So they were used to doing research and keen to encourage to do research as well.
Great. Alison?
I think there's a common aim, wasn't there? It wasn't like different people in different parts of the country were doing different research, which is what would normally happen. All of a sudden, all the academics, all the research was all focused on COVID. And there was collaboration between specialties and everybody. And that's one of the, as I said in my talk, one of the positives that's come out of this is a lot of barriers have been broken down. There's a mutual respect for everybody. And we just wanted to find some answers. And, everybody, even the general public knew about research that was going on where they wouldn't necessarily have done so before. So it's a huge shift in the way it all happened, which I think is really, really good.
Great. Well, we've run out of time. So I just want at this stage to say thank you so much to our speakers for fantastic presentations and for engaging so much in the Q&A. Thank you to Annalisa and the others on the team for all the technical work. And at this stage, and I'll give both of you, Alison and Mike, a call afterwards because we'll have to close the Zoom down. But thank you again for everything. And can I just invite everybody to our webinar tomorrow, which will be Hospitals in the Time of COVID-19 3, the third one, and how to network for support. And that will be looking at the experience of the clinical management support system run by DG Santé in the European Commission. So with that, can I say thank you again and goodbye to everyone.